Hey guys, my name is Sarah Dooley and I am a student at ECPI University. I'm in Nursing 321 Pathophysiology, and today for my course project I'm going to talk to you about juvenile type 1 diabetes and the progression to get into DKA or diabetic ketoacidosis. So the reason this was prevalent for me is I've been working in a pediatric ER setting, and I've been exposed to a lot of this type 1 diabetes, juvenile onset, and the initiation of DKA. A lot of times children present to the ER on the verge of DKA because they don't know they have type 1 diabetes. There's not been a diagnosis made yet. The pathophysiology of type 1 diabetes and the progression of DKA kind of turns out like this. The patient shows up to the ER setting complaining of abdominal pain, looks very pale, fragile, could have some nausea, vomiting, increased thirst, increased urination, and just not feeling quite themselves. So the first thing that we would do is take a blood glucose and look to see if the level is above 300. If it's elevated, then we would treat symptomatically that way. But if it's above 300, then we kind of jump into this mindset that they are in DKA. So the first thing I want you guys to know is that DKA is life-threatening if it's not treated in an emergency setting or in a controlled environment with people that are trained to treat it. So in a patient with type 1 diabetes, they're lacking insulin. So insulin's made by your pancreas, and it is kind of like the key to the gas tank, because you can't get gas in your car without opening the tank. You can't get insulin into your cells without opening you can't get glucose into your cells without using insulin to open it. So insulin's kind of like the key to your cells to get that sugar or energy stores into your body, into your cells, so they can use it. So the only way to treat type 1 diabetes is to take synthetic insulin via subcutaneous injections. So other ways that people can go into DKA if they have type 1 diabetes is if they are either non-compliant with their medications, or they have increased stress or increased illness recently. When the body runs out of insulin, or they can't get the insulin to open the cells to get the sugar, then the body looks for other things to break down for energy. So what it chooses to do is it chooses to break down fats next. Fats are the next easiest thing for the body to choose to break down. The problem is when they break down fats, the byproduct of fat breakdown is ketones. And ketones are very acidic, so it changes the blood pH, and an acidic blood pH would be less than 7.35. So when you're checking for DKA, 3 things that I want you to remember is you're going to have hyperglycemia, ketosis, and acidosis. So glucose is the sugar, and your cells love sugar. And then the glucose gets concentrated in the blood. And so the blood, and even the blood loves sugar, but then once the blood is overloaded with sugar, then it has to go somewhere. So what happens is your body starts excreting that sugar through your urine. And then, so you'll have that hyperurination. And then for your body's compensation mechanisms, if your body can't get rid of the urine and the sugar, then you start drinking a lot, because now you're in risk of dehydration from all that urination. So you're peeing a lot, then you start drinking a lot, and then you can also get symptoms like the Kusmal breathing, which is also a way for your body to compensate and get rid of that carbon dioxide or that acidic levels of your blood, kind of trying to blow off all that extra acid. So what does the body look like? So this patient that came into me, her dad rolled her in with a wheelchair. She was kind of slumped over, looked very lethargic, dark circles around her eyes. She's been vomiting, increased abdominal pain, which is very common in pediatric patients. Her blood glucose level initially with the finger stick was over 700. She has had the Kusmal breathing and kind of like a fruity smell to her breath. the polyuria, polydipsia, which has been going on a few days, and kind of like dry, cracked lips. So that is very common with type 1 diabetes in that DKA state. So you get that polyuria because you're in dehydration or causing dehydration. You get the polydipsia for your body compensating for the dehydration. You're trying to overload and take in more fluids. You get that Kusmal breathing and blowing off that carbon dioxide to get rid of that excessive acid in your body. And then those dry, cracked lips, vomiting, diarrhea, and belly pain. So a few laboratory tests that we do to check the results and diagnose this is especially number one, blood glucose. Anything above 300, we want to treat and bring down and try to search for other answers if it's type 1 diabetic or a new onset or just a risk factor for it. And then especially urine ketones is a big one. Not many other radiologic tests that we can do unless it is a confirmed diagnosis and it's been chronic going on uncontrolled. Then we can have some kidney and liver function impairment, other organs impaired. Our brain is a big sugar consumer, so we can have some brain function loss. But current treatment in the ER setting is number one, hydration, hydration, hydration. So as soon as this young lady came into me, I brought her back to the trauma bay. I didn't even finish the triage process like we would normally do for a sick kid. I brought her back so the provider could assess her more rapidly. He immediately ordered IV fluids and 2 intravenous catheters. One of the catheters is used for routine blood glucose checks because it happens so frequently. We don't have to stop our fluids from flowing in the other catheter while we check the blood on the other side. So what he initially ordered was a normal saline bolus isotonic solution. And what that isotonic solution does is hydrate those cells back up because of all that frequent urination. This young lady was super dehydrated. After that hour goes by with that initial bolus, we do an immediate blood glucose check and then start her on maintenance fluids, which is usually half normal saline with D5, and then start an insulin drip along with that. The insulin drip is titrated based off of her insulin levels, so this is not a quick process. It's titrated over time. Although glucose levels are checked between every 15 minutes to every hour, the titration occurs based off the doctor's order and how well the glucose is being brought down in her blood. So we also wanted to monitor potassium levels. A good potassium level would be greater than 3.3. That's because potassium naturally lives in your blood and your cells, but when you're having this hyperosmotic state, then it pulls it into your blood and you're kind of dumping potassium along with the glucose. But then once you start administering insulin, it kind of opens those cells back up to have the glucose and the potassium go back into your cells. So you have this kind of unbalanced shift going on, and you don't want to cause any kind of damage to the cells or the veins. And then, of course, our overall goal is to correct the acid-base imbalance in the body. So overall nursing care and patient diagnosis, the biggest thing to educate your patient on and kind of figure out what the onset was caused by. Was it increased stress? Was it a sickness or viral illness? Was it or was it non-compliance? Non-compliance is our biggest thing in juvenile patients because they want to be like any other kid. It would be great to go out on a Friday night and have pizza and a soda and not have to check your blood sugar. So it's really unfortunate that these kids have to kind of be different than their peers and monitor their sugar pretty often. So we recommend that they check their blood glucose at least 4 times a day, with breakfast, lunch, and dinner, and then even before snacks and bedtime. If they're sick, then we ask them to check their sugar every 4 hours, which seems really excessive, but that's really the only way to monitor their glucose close enough and to keep it controlled. When a child is sick or under more stress, then they usually require more insulin. They're using up those energy stores more quickly. And then, of course, hydration, hydration, hydration. On any day, they want to be drinking frequently, but especially when they are sick, they want to be drinking or have something at hand at least every hour. And I always just tell them to carry a water bottle and never let it get empty, and then just monitor, how much they're drinking. If they're vomiting or having diarrhea while they're sick, they need to monitor their glucose closely and contact their primary care physician or their diabetes educator if they're having more problems. Overall, medication management is important to teach the family both administration, assessment, and when to seek medical attention if they can't manage it at home or if they have more questions. Because there are multiple types of insulin, long, short, intermediate acting insulin types, and a lot of that can get confusing, especially for a newly diagnosed family. In our hospital, if we come up with a new diagnosis in the emergency room setting, they're in our inpatient setting for at least 3 days for education. So even if they're not in diabetic ketoacidosis or they're not having any current issues with their treatment plan, then they are still seen and educated further for their diabetes. I hope this lesson was, you learned a lot, and I really enjoyed this project, and I can't wait to hear your feedback. Thanks so much.